Bekerja profesional mendunia, semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti di Dharma sebagai pedoman kami. Membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes di Indonesia siap mengabdi nusa dan bangsa. Berbudi luhur, berakhlak berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes di Indonesia bekerja profesional mendunia. Semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti di Dharma sebagai pedoman kami. Membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat.
Thank you. Now we are honored to hear the welcome address from the head of the Department of Medical Laboratory Technology Poltekkes Kemenkes Bandung, Mr. Dr. Randa Iragustira Rahayu Enkes. Unfortunately, she could not be with us this morning. We are pleased to have Ms. Hapijah Ilmi Supa, SPD MSI, speaking on her behalf. Ladies and gentlemen, please welcome Ms. Hapijah Ilmi Supa, SPD MSI.
Nadia. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Good morning, everyone. Alhamdulillahirabbil alamin, and salawat to our Prophet Muhammad sallallahu alaihi wasallam. Respected head of Department of Medical Laboratory Technology, lecturers and education staff, and dear our students, and the honorable our expert lecturer, Bapak Dr. Roni Lesmana. Thank you for very much for your coming in our Zoom today. As the head of the Diploma 3 program at Poltekkes Kemenkes Bandung, it is my pleasure to welcome you to this international expert lecture in medical laboratory technology. Today, we have the honor of our hosting Dr. Roni Lesmana, Dr. MKes Aivo, PhD, from the Faculty of Medicine, Universitas Pajajaran, Ministry of Education and Culture. He will present a lecture on VATPAC subunit C1 and IKBIP as tandem prospective biomarkers for diabetic. This topic is highly relevant, especially for our students, the last level students ya, tingkat akhir ya, who are planning research in biomarkers for diabetes. The insight share today may guide you your study and help you to explore new possibilities in this important field. Yeah, maybe some of our students are planning to do experiment for making biomarkers. On behalf of our program, I sincerely thank Dr. Roni Lesmana for sharing this expertise and the organizing team for the efforts in preparing this event. I hope today's session will bring valuable knowledge and inspiration for everyone involved. Thank you very much, and I wish you a productive and engaging lecture. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Ms. Hapijah Ilmi Sufa, for the warm welcome and inspiring word. Now we move to the main session of today's event. I would like to hand over the session to our moderator, who will introduce the speaker, present his curriculum vitae, and lead the lecture. Without further ado, please welcome to our moderator, Raditya Bagaskara, who will lead the discussion.
Thank you, Nadia, for the time given. Good morning, everyone, colleagues, our honorable lecturer, and last but not least, honorable speaker. Before we start, let me introduce myself. My name is Saditya Bagaskara, as the moderator who will guide the course of today's lecture. It is such an honor for me to be a moderator on today's special occasion. I would like to thank you to all participants for attending today's Zooming and welcome our international expert lecture in medical laboratory technology with the theme of PATPase subunit C1 and IKBIP as tandem prospective biomarkers for diabetics. First of all, let me extend our warmest greetings to our best speaker today, Dr. Rani Lesmana from Faculty of Medicine, Pajajaran University, Ministry of Education and Culture. Good morning, sir. How are you doing today?
Hi, very good morning. I'm good. So very happy to have the honorable session today. So I hope you are also excited to hear the lecture today. So thank you so much.
Glad to hear that. Could you tell us a little about your current activities?
Yeah. So I have two roles in the structural position and also have role in the functional position. I'm the associate professor in the Faculty of Medicine, teaching mainly in physiology, exercise physiology, endocrinology, and muscle physiology. In addition, I also head of strategic reputation global office in UNPAD, and also heading three laboratory for animal laboratory sciences and also for biomolecular technology for checking the molecular mechanism. Quite a lot as a consultant in several companies, and yeah, quite busy. Yeah, it's a bit busy.
That sounds very interesting. Thank you for sharing with us. And next, allow me to share and read your CV first. Here is our amazing speaker for today, Mr. Dr. Tony Lesmana, and his IFO PhD from the Institution of Faculty of Medicine, Pajajaran University, Ministry of Education and Culture. Currently serve as Associate Professor for A. And moving on educational background, a bachelor degree at Pajajaran University, Indonesia for medical doctor from 1999 to 2006. Uh, master degree at Pajajaran University, Indonesia for exercise physiology from 2003 to 2005. And doctoral degree at Guna University, Japan for philosophy of doctor from 2009 and 2013. Next in line for academic and research experience attached. Okay. Next is his experience on community service for the last 5 years and so many journal publication attached. And, and next is for books authored, edited, and reviewed at. And next is intelligence right for Haki, patent and awards attached. And Last but not least, his career as a coach. Wow, our speaker today is so amazing. All his achievements and experiences are very inspiring. Let's give a round of applause for our speaker today. But before starting the presentation, may I remind you to please keep the camera on until the end. Pay attention to the presentation, and if you have a question, please keep it until the question and answer session. All right, without further ado, let us listen to the presentation from our best speaker today, Mr. Ronnie Lesmanos. With respect, we kindly invite you to begin.
Thank you so much. Very good morning, Raditya. Thank you for very kindly introduce me for this event. And then also I'm thankful for all the leaders that give me the opportunity and trust moment to share and discuss with all of you. I'm very happy always to meet the new friends and new colleagues. I'm very happy also to welcome old friends and I know for a long, long time ago. I see in the camera, I'm very happy. One of my good friend, Pak Asep from Tasik also can join. I'm very happy. Good
Thank
morning,
you.
Pak Asep.
Thank you
And
very
then, you
much.
know, this is quite interesting why I also sharing this one with Pak Asep, because I remember Pak Asep working with a diabetes mellitus that we have been discussed for very long time. And when you see the situation of our country today, the syndrome metabolic is still become a very big issue. So, as a researcher, we need to start with small questions. When you see my publication is quite a lot, honestly speaking, it's always started with small questions. What we can do and answering the matters in the society. So, when talking about the research, honestly, research is not kind of something complicated to be done, but research supposed to be and should be answering a simple matter, small matter that we can solve for the society and then give the benefit for them. This title of presentation is quite complicated, right? Agree? Maybe some of you mentioning in your how, what is that? What is Dr. Ronnie trying to explain? But the thing is, it's coming from a very simple idea that we want to have the opportunity to give the good quality of life for the patient who has the type 2 diabetes mellitus by chance to screen them earlier when they have the complication uh, for the chronic exposure that they have because of diabetes mellitus type 2. So allow me to share my screen and then I will not present that long, maybe 30 minutes. I hope that you can stay with me. And then, I'm very happy after that if you want to have some questions and discuss with me. I tried to put my slide in Indonesian, vice versa. Sometimes people speak Indonesian and put the slide in English, but I think that better for me to put my slide in Indonesian and I share in English. So you can try and challenge yourself to hear somebody speak in English and then make you comfortable with that. And I believe it will increase the capacity and capability to speaking in English or either. Today, I'm want to share about how we targeted, okay, targeted the small protein, a new protein as a marker in the low molecular weight levels as a predictor for the complication in nephropathic diabetes for diabetes type 2. Why this is interesting? Because when you have the patient type 2 diabetes, sometimes you never realize on a sudden they go into the complication state already. Micro or microangiopathy, I will explain later. And then when you come to the situation of nephropathy, the protein is already there in the urine. So the simple questions, again, start with simple questions. Can we predict it before the complication started? That's the questions. Can we predict it before the complication started? Then by having the simple questions of research, we try to break down and make this research. So the definition, as you know, diabetes mellitus is a chronic metabolic disease, okay, characterized by hyperglycemia due to impaired insulin secretion. In addition, insulin action, signaling pathway, or both. There is the problem. Chronic hyperglycemia lead to the long-term damage to the organ in many places organ, like an eye, kidney, nerve, heart, blood vessel, mention it. Many of the area of the target tissue in our body impacted by the chronic hyperglycemia. So since this is having the a lot of major complication and then reduce the quality of life of the people, diabetes mellitus become a major global health problem with increasing prevalence worldwide. And people who has diabetes mellitus without realizing their body and quality of life decreasing year by year. So having the information and knowledge back, we to understand that diabetes mellitus defined by WHO or ADA into several types. The most common that we always hear, the type 2 and type 1 diabetes mellitus. There is a difference. Type 1 diabetes mellitus, this is caused by destruction of pancreatic beta cells, and this is due to the autoimmune or idiopathics. And the situation lead into absolute insulin deficiency. There is no insulin level in type 1 diabetes mellitus. But the type 2 diabetes mellitus, usually it causes by the insulin resistance and relative impairment of insulin secretion. So still there is insulin secretion, but the function and the signaling and induction is not that good as a normal people. And this is the most common type, 90 to 98% of the cases. Without realize, type 2 diabetes at the end could lead to the total destruction of beta cell pancreas and lead to the really total absolute insulin dependence and lead also to the complication that we know micro and macroangiopathy. In addition, we also know there is a type called that gestational diabetes mellitus or GDM. This one first recognized during pregnancy and usually resolved after delivery, the baby. And other specific type like a genetic defect beta cell function, genetic defect insulin action, disease of exocrine pancreas, drug chemical induced diabetes, and many, many others. So if we understand, we are talking now the type 2 diabetes mellitus. Okay, don't get it wrong. We go to the type 2 diabetes mellitus. Then what we try to understand in this situation, as I mentioned earlier, diabetes mellitus have a very bad prevalence that increase year by year. In the global prediction, is increased 25% in 2030 and 51% in 2045. Because that reason, we need to be careful, really aware and be careful. It's not only 2045 that we 100 years Independence Day, okay? But the other that one, there's also challenge that we need to really careful that coming over as threatening for our society in Indonesia. Thus, uh, the number of the diabetes type 2 patient, even from the survey that we have in Indonesia, yearly is increased 6.7%. And 2023, the data that we have, it's increased 10%. The estimation prevalence of diabetes type 2 will increase 22% in Indonesia. That's a global prediction. In Indonesia, prediction is 22%. Can you imagine? It's not only talking that we are facing the stunted population, less of nutrition, but we also facing the population that uncontrolled uh, consume the balanced nutrition for the body, lead to the syndrome metabolic and also have increased number of type 2 diabetes mellitus. So in the type 2 diabetes mellitus, there is two things. There is a genes area that affected and also environment and also affected including dietary factor. Both of these play a role, okay, in inflammation and metabolic stress level in our body. Why are we talking about genes? Because diabetics, there is a risk factor inherited from the parents to the son or descendants. And this inheritance and risk factor combined with the environment mentioned, virus, microbiome, physical activity, sedentary living, type of the food ingestion, both of them become a very good combination, induce the inflammation and metabolic stress in our body, lead to beta cell destruction, hyperglycemia, type 2 diabetes, and lead to the complication we call the microvascular complication and microvascular complication. When you're talking about the microvascular complication, we're talking about retinopathy, we're talking nephropathy, we call them neuropathy. When you call the macrovascular, we call them coronary artery disease, stroke, and other things. So need to understood very well, okay, friends. Type 2 diabetes mellitus is really serious matter, unseen for years, and on a sudden, become a very bad situation for the patient. We need to really control carefully, not only modify the lifestyle, also the type of the nutrition that patient taken every day, but we need to really careful, predict it, prevent it with many others uh, marker that we can be used as the tool for screening. Thus, if we understand these two big factor is really impacted to the function and the performance of the beta cell pancreas. As mentioned, the complication of type 2 diabetes mellitus, there is two big, okay? Two big group. First is macrovascular, second is microvascular. When we're talking macrovascular, I repeat one more time, there is a cardiovascular diseases such as coronary artery disease, lead to myocardial infarction. There is cerebrovascular disease, we call that the type of the disease stroke, everybody know that. And then peripheral arterial disease leading to limb ischemic, ulcer, amputation, gangrene. And I know Bapak Dr. Asep in Tasik has a very huge experience handling the gangrene diabeticum, which is not easy. This is macrovascular. But when talking microvascular, even unseen, because inside deep in our body, and on a sudden, the type 2 diabetes patient start not be able to see because the diabetic retinopathy, leading to the blindness, and diabetic nephropathy, leading to chronic disease and may lead to progress and state renal disease, lead to the you need to go to the renal dialysis every week and every month and for whole your life. And then also there is a diabetic retinopathy, which is lead you to peripheral neuropathy, feel itchiness, numbness, pain, ulcer, and they lead to autonomic neuropathy, gastroparesis, orthostatic hypotension, and many other things. This complication is really need to be concerned. In the normal things, okay, in a normal thing, protective factors will protect us for the vascular injury. But in the diabetes situation, the hyperglycemia increase the injury and then reduce the capacity of our cell to combat and prevent this bad effect for the cell injury. And reduce absolutely the vascular defense system. And then we can see why the vascular complication is happening. So if you see in the table, diabetes mellitus causes the hyperglycemia, and also this is followed by increased free fatty acid, increased modified LDL cholesterol, decreased HDL cholesterol. And those two factors lead to mechanism of injury. Why? Because increase of age, increase of ROS, increase angiotensin 2 and FKP tube activity, we call that it is cytokine interleukins, and then also PKC activity. This is very, very annoying in the system of the vascular protection and lead to vascular complication like atherosclerosis, nephropathy, retinopathy, and many others. So seeing these things, this is why the story behind the scene and the mechanism behind the scene lead to 40% complication of diabetes type 2 and lead to diabetic nephropathy. At the end, this patient have less or decrease the quality of life, increase the morbidity and mortality of this patient. So need to be careful. Then we come to the understanding, because I know none of you maybe have a read more deeper regarding the physiology of renal that will talk quite a lot in this session. I will want to refresh a little bit. When you're talking about the function of renal, and then we always have a correlation that function we close with the urine formation. There is a three type of urine formation. Okay, there is filtration, reabsorption, and secretion. As you see over here, when we talking about filtration, which is this is become our main focus of our research for the our discussion this session, you can see that in the glomerulus, renal is not filtrate the water and the blood for the wastings, but also the iron, the glucose, the amino acid or proteins, and some drugs. Thus, if this filtration is not working properly, the reabsorption will not also properly, secretion will also alter. And in this process, we need to really understand that the filtration play a very important things to filtrate all the amino acid and the protein. If we see some protein okay, secreted in the urine means the filtration may face a problem. And in the diabetes mellitus, filtration process indeed a problem. So in the physiological perspective, if you want to read more in your free time, you can understand there is a charge positive negative of the protein and the function of camera or glomerulus in the renal, how it function and how it filter the size and so on. I want to highlight a little bit. If you see here, there is a blood vessel coming into the kidney, into the glomerulus area. It will filtrate it as you seen in the left side, and after filtration it will filtrate it and formate it as urine. Okay, and what happened inside the kidney or glomerulus? So I hope you can see my arrow. So in this area, if we enlarge, see, there is blood waste, and then it will filtrate it here, and the blood filtrated will come back, goes to our bodies, black to without waste, and then after filtrated become urine here, and urine will come here. But when ill filtrated, it's not only water. Again, it also filtrated the protein. Details you can see. This is the type of the cells. There's the juxtaglomerular cells inside the capsule of Bowman, and then you can see how it filtrated. There's a podocyte and so on. This is allowing a very clever renal system to filter the protein from the urine. Okay. If this is not right, something happened. The process is not going smoothly, such as kind of in pathological situation like diabetic nephropathy. We can see there is a limitation in UACR in diabetic nephropathy. So there is insufficient capacity to filtrate the protein, and this is lead to the condition that we can find protein in urine. At the moment, we can detect the albumin-urea with some of the tests in the urine, foam tests and so on. But indeed, when it happened in urine already, the situation is bad already. Agree? Yeah? So if this is bad already, we cannot do anything, and we cannot really revert it earlier to reduce the reduction of the quality of life. So how if we can be able to predict and to predict and prevent this earlier? How we can really catch the moment before it going into the bad situation? So we try to think that can we just screening in urine in some step or in some period before it going nephropathy, we do some screening small protein, which is usually is not detected, and it may already in urine at the earliest stage of nephropathy syndrome. So in that sense, we try to explore a new marker. And with my PhD student, now graduate already, become the head of the brand office in the Prodi, very leading company for the pathological clinic laboratory. And as you seen over here, we understand, that hyperglycemia is causing the cellular dysfunction and lead the capacity of the glomerulus to really filter the protein. And then in the hyperglycemia, there is destruction of the integrity of the capillary wall structure in the glomerulus. And this is caused the release of the protein from the filter process to the urine. And then the idea is simple. It will eat only the big protein released to the urine, or there is small protein will release in the earlier stage to the urine. Will the big one release at the end? The logic is like that because there is a pore and size in the glomerulus. Thus, we try to make some hypothesis. How if we try to detect the low molecular protein weight and utilize that marker as prediction? So we come with the very strange ID, and we have discussion and try to do SPLC in urine. Don't mention, if you ask me to me, is that any problem? Absolutely, a lot of problem. When I have this ID, okay, and the the friends from Singapore, from Waters, who create the company, said to me, nobody checked the protein in urine for SPLC. You are a bit crazy. I said that, yeah, I'm the first person maybe want to check with my PhD student and see the protein in urine. They said that, no, we don't have even the software. So we have the software for the other purposes to see the protein in blood. Would you be able to using that software to check the protein in urine? And we send an email back for, and I think they're a bit angry with us. So the email is not answering for almost 3-4 months, and my PhD student from Faculty of Pharmacy getting upset and getting sad. What to do? Because the time frame is very constrained and we're not getting answer. And at the end, we find the water company said, okay, you can send a sample. Let's try once. Okay, I send the sample and we send the sample to Singapore and try once and see and checking to having also double check with our site and ask for the software for the water's machine, SPLC water machine. And then surprisingly, it's coming out into really interesting result. What result? Let me see like this. So when we have those of the ID, we try to formalize and crystallize first to become the review paper. Then we publish in 2021 about how genomic, proteomic, metabolics approaches and so on to become a prediction for diabetic nephropathy and type 2 diabetes mellitus. So everything you have a simple question with the ID, you need to really check the journal and the building block data science existing in the online or in the library to and strengthening your hypothesis and checking. So we did that. We published this one. We quite confident. Nobody done before. We're going out to the experiment and we said how we will do the experiment. So we have the ethics system, we have the structure for our experiment. So we do screening the subject, okay? After we get the ethical approval, we divide. We want to have a male with diabetes type 2 diabetes mellitus, and the age should 30 to 50. And then we want to have the check physical and screen for laboratorium, quite complete, as HbA1c, creatinine, SGRP, and so on, including the TSH. Okay, and we do exclusion of the data if there is a hyperthyroid or there is a GOT-GPT is increased. And then at the end, if there is no such type of confounding factor, it will come to the inclusion group, and we divide it into 4 groups. First, individual without diabetes mellitus type 2 as a control. 2, we have the group with the patient with diabetes mellitus. 3, we have the patient with diabetes mellitus type 2 with albuminuria 30 to 299 milligram per gram deciliter. And then the third, we have a number 4, we have the patient with diabetes type 2 with the albuminuria more than 300. So we have some staging on that. We collecting this sample of urine. We send from a preliminary, and we got the feedback after we decide the number of the patient and then inclusion and exclusion, as you also seen in the slide, and also we counted precisely the number that we need. And we have this four group that I will mention. 1, 2, 3, 4. The sample we're sending for checking in Singapore after we get approval for the waters, after a very long communication, challenging, tiring, but at the end we got that. What we see, the result. So we want to have the check the proteomics analysis from the friends in Singapore. And this is what we try to do. When we have the sample urine preparation with several step protocols, okay, we do QF, TOF, or time of flight 0 and acquisition, and we can see, the branches, the type of the proteins, and also the details, because we're using a very quantitative log mass calibration, and we can see even very small protein levels into below 50 kilodaltons. And false discovery rate 4% is very low, 4% using this machine. And we detection the peak, alignment, identification, peptide quantification, and also we have the data result at the end with the distribution as you've seen at the right side. Okay, what the name of the analysis program? We call Progenesis Q1. We got it from Singapore. Analysis data helping us to identify, first, identify. Second, quantify. We count it. Third, based on those two data, we can do statistical analysis and bioinformatic analysis. So is the subject characteristic for our experiment. As you've seen, nothing interesting in this one. But again, you can see that albumin, ELG, something changes. Usually there is 400 plus in the normal group, reduce it to 100, 100 even worse, and the group 4 is 85. And then ratio albumin creatinine, as you seen there, 5 and increasing even very bad in the group 4, which is 1,388. And this is absolutely impacted to the blood pressure and then systole and diastole. And this is also correlated with the index mass body. So, based on the data that we have, what is interesting, using the Progenesis Q1 version 4.2, we found, so this has become interesting because even the Singaporean people in the waters company who create the machine surprised because they never checked the urine and expected in the urine a lot of low protein with a small size below 50 kilodalton can be detected. And we detected 73 protein type. And among 73, there is 32 very significant. And this is fulfill the 3 criteria. First, quantify at least there is a 2 peptide and unique. Third, there is a difference. There is significant difference in the numbers because usually there is none, now exists. That's the meaning. And the third, the number of increase more than 1.5. So seeing of this data, this is a very promising. Probably, if we can see this protein, this 32, which is we can divine 1 or 2, the very significant, it could be become a marker to detect and predict the situation for nephropathy earlier before it going into severe situation. So if we put them in the pie chart, as you see, 70% low molecular weight differential, and there is a low molecular protein, it's 30%. So among all, 30% differential protein weight, which is with a low molecular weight, is 32 protein, okay? And based on this data, this is just the protein and the name of the protein. We counted and we found it and all significant. In is a code of the protein ID. So this is quite interesting. You can explore this protein further for the marker and other things. But this protein not supposed to be there in the urine in the earlier stage. No, supposed to be no. But indeed, we found it. Thus, Waters Company is very excited when see this result. How this is can coming out. And something sounds crazy with a simple questions, answer at the end, and may be beneficial for our target society, type 2 diabetes in our country. And this is a heat map analysis. What we can learn from heat map analysis, we can see there is a difference significance increase of low molecular weight protein into 2 clusters. And in these 2 clusters showing the 4 changes of the situation of the group depend on the group of the patient with or without albuminuria. So I put in the figure, you can see this is name of the protein on the right side. At the below, you can see group 1, group 2, group 3, group 4. Okay, so this is showing that how we matrix and how we put the mapping of the protein that we targeted 32, which is important. As you also have been following me since very beginning, there is a toppest one called Phi type proton ATPase subunit C1. It's number 1 as it's very, very high. And the other also, you can see in the bottom side, there is a serine threonine protein kinases VRK1 and inhibitor nuclear factor kappa beta in kinase interacting protein. So there is 3 which is popping up very high in the abnormal pattern. So we put this one as our new prediction target can be utilized as a marker for early situation for type 2 diabetes patient going into bad situation for a chronic kidney disease. This is the pattern of the graphic as you've seen. There is illustration how we predicted the three protein that have been mentioned with a more clearer perspective that Phi ATPase subunit C1 and inhibitor nuclear kappa kinase interacting protein IKB KB interacting protein is very different with normal group, okay? And type 2 diabetes without albuminuria is very different. And serum threonine protein kinase PRK1, as you've seen in the 4-3C, there is a very abundant increased significance, and which is this is maybe along the line and in line with UICR, which is less different in the normal and the MT2 patient group. So this is the simpler differentiation and comparison between normal diabetes type 2, microalbuminuria, and nephropathy in a VRK1, serum threonine kinase VRK1 albuminuria. And this is the protein that we have been talking about. What is serum threonine kinase VRK1? And this protein is very important for cycle cells, apoptosis, senescence, and connection with this protein suppressor. And it has connection very closely with disturbance function of the kidney, and also correlated with, again, as we mentioned, with PCP53, which is abundantly increases the expression in nephropathy patient causes by diabetes, because this is part of the protein because of the obstruction and the destruction of the podocyte. Okay, and interestingly, this is not showing the significant changes at the earlier step, but showing a very big difference at the later step after there is renal failure. So this is may have some potential exploration for us in the future. So this is ATPase subunit C1. As you know, that the number of C1s showing a significant increase and decrease after the subject has the albuminuria, and showing that maybe Phi ATPase subunit C have an inverse trend bit ratio ACR, and this is important with ACR and Phi type proton ATPase subunit 1, and give us the clue that may this anomaly change inverted with may our mirror to see the functional of the kidney at the earlier stage before it fall down into nephropathy. So we propose that Phi ATPase subunit C1 as potential biomarker because it reducing in the urine as increasing of UICR. And in this situation, like diabetes and hyperglycemia, reducing of Phi ATPase, it also causing reduction of the flux of autophagy. Autophagy is part of the functional physiologist I'm really interested with. I have a publication with this topic later on, maybe in the other time, if we have some opportunity, I'm very happy to share. Again, some of friends, colleagues, know very well that I'm working with this one. And you know, there's inactivation for ATPase concentrate in the intracellular vesicle with little expression in epithelial membrane, which is this inhibit the ATPase significantly, reduce the lysosome function, and connects it with the autophagy. So this is part of the theory why the autophagy come into the highlight. Thus, ATPase subunit C, we believe, could functionally, potentially working as predictor before there is an injury or destruction of the renal capsuloboma and the process functional in the kidney and coming into albuminuria. So we propose this one. And the other three, the last one is the inhibitor of nuclear factor kappa B kinase interacting protein, AKB-KBIP. As you see over here, this is showing the different pattern, increase of albuminuria. This has also become one of the target potential marker that we can use for prediction of the patient type 2 diabetes mellitus, and hoping this is can help and prevent the situation of the type 2 diabetes mellitus getting worse if we can predict it earlier. So this is how we propose the mechanism IKB-KBI IP as the complex of Akeki or uh, uh, the process for the injury of the renal area, causing specifically the podocyte detachment and GBM rupture. Okay, so all of these have been presented sequentially in the conference, national conference, international conference. I just showing part to part, and then all those data has been published in a very high journal, Q1 Diabetes Research and Clinical Practice, because we hope that at the future, maybe 5, 6 years later, somebody will use this one as a marker and really utilizing this one to helping the society prevent many of the type 2 diabetes patients fall into diabetic nephropathy at the end and getting a very good uh, quality of life and compliance. So what is the conclusion? When we come to the conclusion, everybody wake up. So please wake up. This is what we have been talking for 30 minutes, guys. First, we have profiling 73 low molecular weight protein identified in a type 2 diabetes mellitus urine sample. There is 32 low protein molecular weight difference among the type 2 diabetes mellitus without a renal failure or without renal injury or without renal problem with a renal problem. So there is a 2 protein low molecular weight, which is very important. We highlighted at least, fit ATP subunit 1, AKB, KBIP, which is showing a significant difference and potential become a first earlier marker to prevent the patient fall into the diabetic nephropathy, because it can be utilized as our alarm and awareness to give some treatment in the daily activity or in the nutritional modification and give also treatment for the patient. So I'm sorry, the slide is a bit messy, but this is the last slide, I promise you. Okay, I believe we need to do more research and explore deeper how we can utilize this type of the protein as a marker. There is 30 protein. We only try to spotlight 2, but the other 30 can be utilized for the other purposes and very significant to do a staging for diabetic nephropathy in the future. We think we need to have a deeper insight and then read more about the what data has been available on the table, because this is already 1.5 years since published. I do believe a lot of researchers across the world have interested with this topic and also try to understand deeper what they can do. So without further ado, thank you so much for giving me a very kind attention. I'm very happy to take any questions from you. Hopefully it's not too fast. Hopefully you can follow the explanation. Again, thank you so much. Very good morning. Assalamualaikum warahmatullahi wabarakatuh. Hatur nuhun.
Waalaikumsalam warahmatullahi. Thank you so much, Dr. Ronnie, for your amazing presentation. And now we will open the floor for questions. If you have a question, please raise your hand first.
And don't worry, okay? Don't worry if you want to asking me in Indonesian. I'm also very happy. I'm Indonesian, so don't worry. Asking me in Indonesian, I will answer you. Don't worry to ask me in English. That's fine. But asking me regarding this lecture also, okay? Do the other things.
Oke, Manitian,
Silakan Pak Asep.
ya sebelum panitia mungkin saya ingin menyapa guru terbaik saya nih ya. Okay, I am very interested in research of complication of type 2 diabetes, Dr. Rani, and on kidney using multicenter research method and publication in Q2. Amazing, Dr. Rani. This research is very important because if a patient goes into kidney failure, it will go into heart failure, isn't it? Which is more fatal and deadly complication in the future. I hope we can join research related to diabetes between Unpad Poltekkes, Bandung, and Tasik. Thank you, Dr. Roni, for your extraordinary presentation, and thank you to committee. My warm regard to Mr. Erlanda, Mr. Harris, and Mrs. Windy, it is my friend in Kewadiran. Ya, ya. Eh, Dokter Rani mohon izin,
Ya.
kami mendapatkan kemarin itu ada dari Thailand ya. Ada yang mengatakan katanya sekarang ada tipe 5 di
Hmm,
mana
hmm,
tipe 5 itu akibat gangguan nutrisi.
hmm.
Maybe we would like to about this information about the five type of diabetes. Katanya ini karena gangguan nutrisi. Apakah di Indonesia sudah sampai pembahasan ini, Dok, di Unpad? Terima kasih.
Okay, Pak Asep, thank you so much. Did my voice sounds clearly?
Ya,
Uh,
very very clear.
Okay, diabetes type 5 is a severe insulin deficient diabetes mellitus or SIDD. Ini tipe yang sangat berat. It's distinct form, a bit different of the diabetes, which is we always already generally known, recognized by International Diabetes Federation. Usually, this is severe situation because of the chronic insulin deficiency and poor pancreatic function, typically in the early life malnutrition. Betul, seperti yang Pak Asep bilang. Characteristic by low insulin and poor metabolic control, affecting usually the person who have the posture, a thin individual. Often children, young adult, and usually, is come from country who has a low economic levels. And then the
Ya.
mechanism, unlike type 1 or autoimmune or type 2
Hmm.
insulin resistant, in this type diabetes, the body cannot produce enough insulin because the pancreas is unable to function optimally.
I see.
Not because broken, but function is not optimal due to still explorative mechanism is going on. It's not really a clear state what is the mechanism, but indeed this is closely related with the metabolic profile who malnutrition and have a very poor blood control sugar for type 5 diabetes mellitus. Hopefully it's clear and give you over
Ya,
Pak Asep.
ya, terima kasih. Saya mendapatkan informasi tambahan. Jadi, ini kan kemarin sekilas informasinya sekarang very very clear. Thank you. Maybe for future kita akan teliti yang type 5 ini karena katanya berhubungan juga dengan stunting yang sedang
Betul,
merajalela atau
betul,
yang sangat seksi untuk diteliti ya, Dok ya.
betul, betul,
Mohon
betul.
izin, mudah-mudahan kita segitiga bermuda
Ah,
Unpad Tasik
bisa.
Bandung ingin meneliti tentang ini kayaknya pemerintah sangat-sangat menarik. Mudah-mudahan kita bisa menyusun proposalnya Dok ya, mulai in silico, in vitro, in vivo.
Betul,
Insya
betul.
Allah saya sangat
Insya
menarik.
Allah. Insya
Terima
Allah. Ini
kasih
menarik,
Dok
menarik
sudah
sekali.
sudah support. Eh, Hadirin ini adalah sosok guru terbaik malaikat kami di Unpad.
Jangan.
Terima
Ya.
kasih.
Terima kasih Pak
Terima
Asep.
kasih.
Hatur nuhun.
Ya.
Hatur nuhun
Nah,
Pak Asep.
silakan barangkali teman-teman atau mahasiswa ada yang mau bertanya. Terima kasih. Mangga. Assalamualaikum.
Waalaikumsalam Pak Asep. Hatur nuhun.
Mohon izin dok,
Ah iya Bu.
ya ya
Mangga Bu Ani.
ya ya ya. Saya ingin bertanya ya, tadi presentasinya sangat bagus ya. Jadi kalau saya simpulkan tadi ada biomarker untuk em, yang sudah DM, tapi untuk mencapai ke neuropati diabetik gitu ya.
Betul.
Neuropati diabetik. Nah ini ada nggak dok yang em, biomarker, biomolekuler marker untuk
Hmm.
menentukan apakah dia itu nantinya DM atau tidak gitu.
Wah, pertanyaan menarik. Pertanyaan menarik sekali Bu Ani. Itu bahkan lebih awal dari apa yang kita kerjain. Sangat sederhana, pertanyaan sangat sulit dijawab. To the point aja. Karena pada saat orang mulai berubah masuk ke prediabetik itu nggak kelihatan kayak normal.
Ya, ya.
Totally kayak orang stunting normal gitu. Kalau orang stunting itu nggak kelihatan, udah stunting baru kelihatan tuh kecil gitu ya. Tapi kalau cuma stunted kurang aja gitu agak susah. Nah, kalau I catch the questions correctly. Kalau saya menangkap pertanyaan secara tepat, bukan bertanya fase transisi awal supaya kita bisa tangkap kapan dia mau jadi diabetes begitu. Kalau fase ini kita sebut prediabetes, tapi kembali prediktornya belum ada Bu, belum ada yang benar-benar mengeksplor di situ. Dan ini tricky, nangkapnya tricky. Nah, ini juga sama nih, di urin kan kita mau tangkap nih. Dia udah DM, tapi kita nggak tahu nih kapan DM ini jadi nefropati gitu. Jadi kita tangkap nih, ada nggak marker yang rilis di awal sebelum dia jadi nefropati. Sederhananya begitu. Ada dua nih kita dapat. Nah, untuk yang pertanyaan ibu, saya belum pernah baca itu ada. Nah, kalau itu ada, itu hanya kriteria sederhana. Gula darah, respon, apa gitu. Tapi marker tuh nggak ada, Bu, belum. Dan itu menarik mungkin kalau kita bisa explore. Dan itu sekali lagi pertanyaan sederhana tapi sulit. Saya nggak tahu jawabannya. Saya rasa belum ada yang benar-benar explore details begitu, Bu. Pengen tahu banyak tapi benar-benar bisa dapet tuh di mananya kayaknya kayaknya belum, Bu Ani. Menarik
Ya,
itu, Bu.
ya, ya. Banyak sebenarnya mahasiswa yang bertanya ke situ dan mencoba mencari dengan docking itu, dok, dengan cara docking untuk melihat biomarker.
Betul. Kalau kalau docking kita melihat interaksi antar protein, Bu. Sehingga memang agak sulit kalau pakai docking target langsung untuk melihat part to part interaction antara misalnya glukos dengan beberapa gen tertentu karena itu akan banyak sekali dan perubahannya. Karena itu yang keluar ada KF faktornya aja bagaimana berapa kuat dia berikatan. Nah, yang harus hati-hati kayak tadi tuh kalau di urin yang di ginjal pada saat dia rilis itu ketahuan tuh harusnya nggak di situ
Ya,
dan harusnya dia nggak meningkat. Nah, pertanyaannya ada nggak yang gen tertentu atau protein tertentu yang berubah pada saat fase transisi tadi? Nah, bayangkan kalau kita langsung docking, berarti kan tuh kalau docking kita udah tahu nih duanya apa. Betul ya Bu ya, duanya apa baru di docking, baru ketahuan tuh nempel. Jadi menurut saya idenya sangat baik, tapi kalau docking kayaknya agak susah ngejawabnya Bu. Harus pakai teknik lain kayaknya. Jawabannya itu.
ya. Makasih, dok.
Sama-sama Bu, sama-sama. Mangga silakan teman-teman, mumpung saya di sini kalau ada yang mau tanya, boleh dengan senang hati. Ini Bu Dini kayaknya nggak bisa on cam ya. Saya coba jawab ya Bu ya. Absolutely. A lot of things we can explore for the vocational student. If you are interested in the topic that have been mentioned, as you've seen, there is 32 protein, only two that I've been explained. So the other 30 protein, you can do it in silico like Ibu Ani has mentioned with the ID. If you have the in silico study for the 30 protein connected with the diabetes mellitus clinical symptom, you may found something. Gampangnya begitu Bu Dini. Dan other type, absolutely we can explore A, B, C, connected with the herbal, connected with the active compound from the plant, active connected with the daily life modification, connected with nutrition, absolutely. We can do that. But simply from what I present today, what we can do with the vocational student, and this is very connected with what Bu Ani just mentioned, there is a 30 protein left, not been studied for details. If you do in silico, you can just do this protein, do docking with the other target, receptor, mechanism protein, downstream, upstream, whatsoever. We can do 30 of study in silico with the student and getting out 30 papers easily. Gitu, Bu Dini. Semoga menjawab.
Yes, to Najmi.
Okay, thank you for the opportunity. Allow me to introduce myself. My name is Najma Malaysia from class 2B. Sir, in your opinion, which approach is more effective for diabetes research, using protein-based biomarkers or genetic-based biomarker? Could you kindly explain? Thank you.
Thank you. Interesting questions and good questions. It depends on the scope area that you want to explore. Sometimes using the gain expression screening method is easier because it comes from many other type of the tissue sample that we can utilize. And it's a massive, we can screen easily mass number of the sample we can do in once. But a protein is not that easy. Kind of like you, the sample you see in the paper that we have been mentioned, it count one by one and utilizing the time of flight and using SPLC, time consume, and also very details you need to making charting, plotting, analysis is quite long. So depend on the target that you expected. when you're setting out the target or scope of the experiment that you want, utilizing the genetic expression screening or utilizing the proteinomics approachings is both is good. Depend on the scope and expectation target. So, diabetic research field need both, not only one. Both is important, and you need to choose which suitable with the research um, scheme that you want to implement it for your study.
Okay, thank you, sir.
You're welcome.
Is there any more questions from the participants?
See, there is two questions,
Uh,
I think.
uh, to Miss Fuji.
Yeah, thank you for the opportunity. And I'm sorry because I'm not using the background because I have something trouble with my setting Zoom camera. And in your opinion, sir, which approach is more effective for diabetes research using protein-based biomarkers or genetic-based biomarkers? And yeah, could you kindly explain that? Thank you.
I think I answered it already. I don't know whether you hear or not. I think that both approaches is important. Depend on the target or the research scoping that you want to do for answering the hypothesis that you have. Because we can use genetic for wide screening and do in once a very short time, okay, but you for proteomics you need to do one by one in time consume a deeper analysis. You need to plotting, charting, analyzing the data and understand at the end, and it's really depend on the target. Maybe that's the answer. I just try to make more brief general description more to you. Hopefully it's answering.
Yeah. Thank you for the answer. Maybe I apologize if I missed this
No,
earlier.
that's okay, that's okay,
Thank
that's
you.
okay. You're welcome.
Uh, are Miss Nadia have a question?
Excuse me, sir. I apologize if I missed this earlier. How do PLTPH subunit C1 and IQBIP function if they are not used in tandem? Do they still have potential to be applied independently in diabetes detection?
Yeah, because normally this two protein is not appear and then have a normal regulation as the target of the function for the renal um, performance. So if I may to share the screen, okay, I coming back to the ATPS subunit 1, C1. If you read carefully the sentence, the abundance of the VATPS subunit C1 is showing, okay, decrease number of the levels found in the urine. And this is found in the subject with albuminuria. Mean the number of the protein increase, the function is decreased. It's not good. It's inverted trending. Absolutely, this is have connection with the function controlling of the filtration process in the kidney. Okay. Um, if you be able to have some more time, you want to see the function filtration in the kidney, and this is helping you to helping you to understand better about the VATPS one function. Unfortunately, I didn't put the specific name of the protein in this figure, but you can find in the other schematic figure from the guidance, whereas the VATPS subunit C1 have a function for the filtration process. So hopefully this is answering you about the correlated and tightly function between AKB, KBP, and also VATPS subunit C1. Okay. Hopefully this is answering you, Nadia. I know it will not 100% getting into your frame, but I think you need to read and you may easily more understand what I tried to explain to you just now.
Okay, thank you, sir. It's really increased my knowledge.
Thank you, Nadia.
Okay. Uh, Ms. Nadia's question might mark our last question for the Q&A session for today. Time feels so fast. The presentation session and question and answer is over. But before the end, let's give a round of applause reaction again for our best speaker today. Thank you, Dr. Ronnie, who took the time to attend and give very useful knowledge. And have a nice day. Hopefully, we can meet on another occasion.
Thank you so much, Raditya. Thank you, everybody. Thank you so much for the time. So it's closed already. Can I leave the Zoom or still any other things?
Yeah, before we end, let me read the conclusion. DN is a chronic metabolic disease characterized by hyperglycemia due to impaired insulin secretion, insulin action, or both. This is a major health problem worldwide with increasing prevalence from 25% at 2030 and 51% at 2045. From the experiment, there has been found 73 low molecular protein that has been identified at DNT2. There's 32 low molecular weight protein with significant difference in DNT2 between a person with non-acne and with kidney disease. There has been caught two protein with significant difference, which is VATPA subunit C1 and IKBKPIP that should be a potential and as an early marker. I am Raditya Bagaskara as a moderator to sign and give back the event to our Master of Ceremony, Miss Nadia. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much to our speaker and moderator for the insightful presentation and discussion. Thank you for your kind attention, and we look forward to seeing you in a further academic event. With that, I officially close today's session. Have a wonderful day. Untuk para partisipan, sebelum menutup acara hari ini, boleh on cam terlebih dahulu. Sekarang akan ada sesi dokumentasi. Oke, dimulai dari slide 1.
Ada nggak?
Slide 2. Nah. Slide selanjutnya. Baik, untuk sesi dokumentasi sudah selesai. Untuk para partisipan dan Bapak Roni sebagai pemateri hari ini, terima kasih banyak. Dari saya sebagai moderator, pamit undur diri. Maaf, dari saya sebagai MC, pamit undur diri. Wassalamualaikum warahmatullahi wabarakatuh.
Iya,
Waalaikumsalam
Waalaikumsalam
warahmatullahi
warahmatullahi wabarakatuh.
wabarakatuh.
Tenang, tenang.
Ini Pak Roni, Pak
Makasih
Saya,
banyak. Bu, makasih
teman-teman semua
banyak
terima
ya
kasih.
semuanya.
Terima kasih banyak.
Lebih kurangnya mohon maaf. Semoga berguna
Iya,
ilmunya.
terima kasih
Makasih
banyak Bapak.
banyak.
Thank you very much, Sensei, Ku.
Thank you. Thank you Pak
Terima
Asep.
kasih,
Sehat
Bapak.
Terima
selalu.
kasih dok, terima
Atur
Terima
kasih.
kasih Pak
nuhun.
Saya, Bu Ani, Bu
Sehat
Dini,
selalu ya.
Ya,
Mari
sama-sama.
atur
Ya.
Nur
nuhun.
Farida.
Mangga
Terima
izin live
kasih
ya.
panitia.
Ya,
Ya,
Atur
terima
nuhun.
kasih Bapak. Assalamualaikum. Salam.
Waalaikumsalam.
Assalamualaikum warahmatullahi wabarakatuh.